Pathology isn't everybody's cup of tea, but my remit today is to try and explain to you a little bit about how your bone marrow works and what's going wrong in it that gives rise to the myeloproliferative neoplasms. There isn't time to cover absolutely everything that your marrow does normally and does wrong in myeloproliferative neoplasms, but I'll try and, I hope, give you a narrative thread about why I'm telling you the things that I'm mentioning. And we'll focus very much on megakaryocytes because I think they're very key, and I think they're fascinating cells and shed a lot of light on what's happening. So let's get started. So what does your bone marrow exist to do? You're probably very familiar with this, but actually it's there to produce all your red blood cells, all your white blood cells, of which the ones we're particularly thinking of today are your granulocytes, the WBC in your blood cell count, the neutrophil polymorphs, they're the cells that fight infection, and the platelets, the sticky bits that we need to stop our cells bleeding. Our bone marrow has to be producing those all the time because we are losing them from the peripheral blood every day. The activity of the bone marrow has to vary throughout life, and it varies in different parts of our skeletons in different parts of our life. So in babies and infants, actually almost the entire skeleton has to be productive in making blood cells. But as we get older, the active marrow tends to retreat towards the centre, and it'll be our spine, maybe the skull, pelvic bones, central bones that remain active in bone marrow production. And that is why, for those of you, many of you in the room who will have had your bone marrow sampled, you'll know that the back part of your pelvic bone, the iliac crest at the back of your pelvic bone, is often where the sample is taken. So many of you will have experienced curling up on a couch to have the not entirely pleasant experience of having a needle introduced into the back part of your pelvic bone to sample the bone marrow, as this cartoon is showing. The needle has to go through the hard part of the bone, which is the bit that gives the bone its structure and hardness to help us stand up, and it goes through into a soft, spongy central part, which is where your bone marrow actually is, and it's the kind of red bit in the cartoon. And the red marrow is mixed in with spicules of bone in there, and the idea is that the sample is taken in two parts. Most of you will know that actually you don't have just one needle usually, you have to endure two. The first is an aspiration needle, which sucks out a sample of your bone marrow, a little bit the way a blood sample might be taken from a vein. And from there, cells can be sent to have the important genetic tests that need to be done, some other tests to look for blast cells that might be done, and also some are spread on a slide and looked at in the same way that a film of blood might be looked at under a microscope. But the second needle is the trephine biopsy needle. It's bigger. That's the bit that tends to come to my laboratory as the sample that I look at mostly. And that gives us, rather than a liquid sample that's sucked out, a solid sample. An actual small cylindrical core of tissue is removed, processed so that it's preserved and won't decay, and sliced very thinly so we can look at that under a microscope. And the advantage of that second type of sample is that because the cells haven't had to be sucked out, their spatial relationships to one another are retained, and the background tissue, the blood vessels, the bone, the fatty tissue that's around them, are preserved as well. And we can actually see how the cells sit alongside one another, and that gives us a lot of information that you can't get from the liquid sample. And the other thing I'd say here is that if you have myelofibrosis, whether it's primary myelofibrosis and there's increased fibrous tissue in the marrow at the start of your knowledge of your disease, or fibrosis has developed subsequently, sometimes when you try to aspirate the first part of the sample, nothing will come out. And you'll kind of see from my pictures later on why that happens. But then the solid core becomes all important, because if you have no liquid sample, you've got to absolutely get the maximum information from the solid core that you take. So a trephine biopsy, I hope this picture isn't too horrific, is a little bit like taking the core of an apple. But the reassuring thing about this picture is that the sample that's taken is actually about the size of the stalk of the apple here. So what is actually obtained is something that literally is just like this piece. So that gives you an idea of what the real size of the piece of tissue is that's taken. Now, I hadn't got examples, I'm afraid, of what happens to that in the lab, but basically, if we think, I've drawn a little cartoon here, my little red stripe along the middle is that core, that little apple stalk, and it's been processed to make it soft enough by removing some calcium so that it can be sliced really thinly. It's been mounted in some wax, which is what the slightly cloudy stuff is around it, which gives us something that we can also, again, it gives us something that we can cut very thinly. And the red in the background is just a plastic support to hold it all rigid. This is what is then taken out of the laboratory and sliced really thinly so that the slices can go on glass microscope slides for us to examine. And basically what's happened, we've gone from a cylinder of tissue, cut a thin stripe down the middle, or the equator of it, and that's what's now on the microscope slide, again represented by my red bar here. And that's what I would look at under the microscope to try and make a diagnosis of the tissue. The two parts of the specimen, the aspirated part and the trifine biopsy part, are very equivalent in many ways, and I'm just showing you a comparison here between a megakaryocyte, a platelet-producing cell, as you might see it in the aspirated sample, and the same cell as you might see it in the trifine biopsy section. So actually there are lots of things that are very similar, but what you'll see is in the background of this sample, the background is dispersed. It's a mixture of some purple blobs that are cells and some brownish blobs that are blood. Whereas here, there's a structured tissue in the background. This is an empty space where there's some fat. And here are other blood cell forming types, other cells in the marrow that are making different types of blood cells. And they have a kind of spatial organization, which is part of what we're recognizing. So I'm going to come back a bit more to some of those spatial and organizational aspects in a minute, but one of the things I want to try and get across is how many cells the bone marrow is trying to produce. And when you have a myeloproliferative neoplasm, the proliferative bit of the name is telling you that the bone marrow is overproducing. How do we recognize that when we've got the samples in front of us in the lab? So there's this normal level, and actually from our tissue samples, we can normally do that pretty roughly by seeing how much active marrow cells we can see to how much background. And roughly speaking, because the background tends to be empty looking and fatty, the background is actually quite fat cell rich in normal people, we can tell that at birth it should be 100% bone marrow bone producing cells and not much else. At about 50 years it's about 50-50 bone marrow that's productive, and stroma, fat cells, tissue, other things in the background that aren't productive. And by the time you're in your 90s, then only 10%. So there's a decline over the years. There's an important point here in that if you're a young patient with a myeloproliferative neoplasm, because the level of activity in your bone marrow is naturally quite high, it can be quite difficult for us to tell, is there too many? Whereas if you're an older patient with a myeloproliferative neoplasm, because the natural, normal level of activity is lower, it's actually much easier for us to say, oh yes, that's too many. So sometimes actually it's a harder or an easier job depending on the age of the patient's sample, the patient for whose sample we're looking, or other things we know about them. So bear in mind, this is a subjective assessment. It's not just going into a machine, it's being assessed by a human being who's trying to do these kind of calculations based on other things that we know about you. So here's just some examples of different real microscopic slides of bone marrow trifine specimens showing how that cellularity, the activity varies. So this is a rather empty one up at the top. It just looks white, apart from the pink bony spicules. This is just over 50%, so empty fat spaces make up nearly 50%. We kind of discount the bony spicules, and the pink stuff in between is the cellular bit, the active productive bit. Slightly higher magnification down the microscope, but this is a more cellular specimen. And then this is a marrow where the cellularity is very high and the productive marrow is almost everything, and there's almost nothing that's kind of background. So for almost anybody, apart from maybe, if this had come from a baby, this would by default be far too many cells. So then we need to know what are the cells that we are seeing. The first thing I'd say, I'm going to show you this slide, and I'm going to talk you through it very briefly just to highlight where the different cells are and how we can begin to see that they have relationships in space with one another. One of the things that I will say from the outset is, you know that one of the things that we're thinking about when we're monitoring your blood and your bone marrow is, are there any blast cells in there that shouldn't be there? And it's one of the jobs for which the Trifine biopsy specimen is not very good. The aspirated sample is much better because there are other ways of looking for those blast cells in that sample that are not so easy in the Trifine. So what can we see? This little area in the middle where you can see some bluish cells grouped together, this is a little cluster of red cell production. And that's what we look for. We can recognise that as being the formation of red blood cells. Don't worry about the details, but they are quite distinctive, and you'll see that area does look quite different from this neighbouring area that I've highlighted. And this is an area where granulocytes, mainly neutrophil polymorphs, are being made. There are some eosinophils, they're the darker cells, but again, don't worry about the detail. What this is showing you is that the red blood cells develop in a different part of the marrow from the white blood cells. And then my final marker on this slide is, here is a megakaryocyte, a big cell, much bigger than any of these others. These are the cells that make the platelets. And they're called megakaryocytes because they are so big. And again, there's a spatial relationship. Notice that the megakaryocyte is sitting here on its own, whereas I've highlighted clusters of cells for the others because the other types of blood cell tend to develop in groups and clusters. So that's something about the cells, and we'll come back to those in a minute. The other component about bone marrow that you know about a lot is the stroma, because you know that we're monitoring whether you have fibrosis in your marrow or not. And that's a key component of the background stroma, the supportive meshwork in which these bone marrow cells develop. And there's a scoring system for these, so we like scores in pathology. This isn't directly related to any clinical features that might drive your treatment, but nonetheless we put a score against the fibres in bone marrow to allow us to have a consistent way of recognising and noting how much was there. So if you have a score of 0, it's a scoring system espoused by the World Health Organization, so they're called WHO scores. If it's a 0, that's normal, and that just means you have a few fibres illustrated by the black lines here. And they don't, in a section as we see it under the microscope, they're so fine and delicate they don't really meet up with one another very much. As the score rises, 1, 2, and 3, progressively the fibres become more apparent, and they crisscross one another more, and eventually they're a dense felt work. By the time they get to a WHO 3, this is almost like having scarring going on in your bone marrow, just as you get scarring in other parts of your body. These fibres are called reticulin fibres, but they are the basis on which another molecule might know about called collagen is made, and collagen is the stuff of scars. So as the score goes up, the reticulin fibres are progressively building up, and by the time they're at a score 3, they're turning into collagen fibres and turning into really quite dense scar-like material, and that's the point at which the fibrosis may begin to really impair the functioning of the bone marrow in terms of making blood cells. We can see the fibrosis. One of the things I'm trying to show you in the background of showing you these slides is that we can apply a lot of different staining techniques to these microscopic sections to highlight different components. And this is a stain done specifically to highlight the fibrosis at the stage that it's become collagen. In this slide, there's some bone around the edges which has this mixed red and blue picture. This is a blood vessel, a normal component of bone marrow, and collagen, which is normal around such a blood vessel, is blue. But there shouldn't be blue elsewhere in the background. And the fact that there's blue elsewhere in this particular picture is because the reticulin fibres in this particular patient have become massively built up and have begun to turn into collagen, and that is now impairing their bone marrow function. So we can look to see whether that conversion and development of collagen has happened and comment on that in our report. Now, what's the link between the cells in the bone marrow and the fibrosis that happens? Fibrosis, a tendency to develop fibrosis, as you know, is there in the background for all of you as patients with myeloproliferative neoplasms. But it's a result of having the disease. It's not a cause of the disease in its own right. A stem cell in your bone marrow is not producing the fibrosis. How does it come about? It's not entirely clear, but it seems to come about mostly because of inflammatory molecules that come from platelets or come from other cells that are themselves attracted by the presence of platelets. And you might know these hieroglyphics of platelet-derived growth factor, PDGF, platelet-derived endothelial growth factor, PDEGF. Don't worry about the names, but just these are some hieroglyphics that describe chemicals that can drive fibrosis in your bone marrow. And a conundrum, a mystery is that the platelets in myeloproliferative neoplasms don't behave any much better or worse in many circumstances than normal ones. So why do they cause fibrosis in bone marrow of myeloproliferative patients when they don't normally? So I'm going to tell you a little bit about the story about why megakaryocytes are so clever. And although they create platelets which are incredibly inflammatory and incredibly prone to cause fibrosis, they don't do this in the normal bone marrow. And unfortunately, they have a tendency to do it in a myeloproliferative bone marrow. This is another stain, which given the glorious name of CD61, which stains megakaryocytes brown because it's staining the platelets brown. This is a megakaryocyte. It has multiple nuclei, and it just has these tendrils around the edge, which are where the platelets are going to come from. And normally it looks compact like this, and the rest of the bone marrow is pretty clean. Where it's blue, that's just other blood cell forming types that have nothing to do with megakaryocytes, and so they're not stained brown. This is what happens in a really fibrotic myeloproliferative marrow. The megakaryocytes are still in here, but they're hidden in a snowstorm, a blizzard of brown, as stained here, platelets that have been shed into the bone marrow. And the message is that actually normally your megakaryocytes don't shed any of their platelets inside the bone marrow if they can help it. They shed them directly into the bloodstream. How does that happen? Well, a megakaryocyte starts as a small cell we can't see, and as you've seen in the real examples, as it matures it gets bigger and has multiple nuclei and lots of cytoplasm, the blue stuff that's full of platelets. They die by undergoing a process probably that either is the same as or very similar to the way many cells in the body die. It's called apoptosis. They shrink down on themselves and are engulfed by other cells. It's a very safe way of dying. But as megakaryocytes do this, that's the point at which they normally shed their platelets. And they do this normally by coming very close to a little blood vessel in the bone marrow. So the stroma and the reticulin fibers are all over on this side, and the bloodstream is flowing through here, and they only ever shed into the bloodstream. They shouldn't ever shed into the background stroma. And even more clever than that, they don't shed the platelets in their active form. It's like having a boiled sweet inside its wrapper. The platelets have a wrapper around them as they're shed that keeps them from being active. And only once they're out in the bloodstream, the inactive proplatelets only then shed their wrappers to become active. And this is a second kind of safety mechanism to protect the marrow from being led to produce fibrous tissue in response to the presence of platelets. So it helps us understand why some patients are more likely to have fibrosis than others. And you'll see as I show you some examples why, again, there might be more fibrosis in some circumstances than others. But let's spend the rest of the time mostly just showing you what's happening in your bone marrow with the different types of myeloproliferative neoplasm. If you have essential thrombocythemia, really only your megakaryocytes are increased and abnormal. The rest of the bone marrow looks remarkably normal. And this is an example of this. Very big abnormal looking megakaryocytes, but the rest of the bone marrow actually looking remarkably normal. And because this is your picture, these megakaryocytes are really benign and healthy. They're larger than normal because they've become older than normal, but they've kind of forgotten how to die, and they don't shed too many of their platelets abnormally, so the tendency to fibrosis is relatively minor. And they also don't cluster together because they're relatively normal. They're just a bit bigger than normal. Clustering is something that we've recognised as abnormal, and I'll come back to that in a minute. What happens if you have polycythemia vera? This time round, all the cells in your marrow are increased, and they're much more, the megakaryocytes in your marrow are much more atypical. And this, I'll show you an example in a minute so that you can see. And the other thing that you'll see is that they're much more tightly clustered than normal. And there's something going on here that enables them to shed more platelets into the marrow, and hence there's a bit more tendency for fibrosis. So I'm just showing you a schema to show you the way this is what a polycythemia vera abnormal megakaryocyte looks like. And I'll show you a real example. I'm going to scoot on so that I don't overrun my time too much. They cluster a lot, and they overlap a lot with what happens in fibrosis. So in fibrosis, you'll know that fibrosis sometimes presents before the fibrosis has really developed. The marrow then looks very much like it looks in polycythemia vera. Hard to tell the difference sometimes, but very similar features in many ways. And it looks like that, so not so very different from a polycythemia patient. Whereas if you've got advanced myelofibrosis and the fibrous bit is more advanced, the cellularity of your marrow is much lower, and the picture is much more dominated by this fibrosis that's in there. And this is an example of a patient. The pink swirling background is telling us that there's fibrosis in there, even though there are still quite a lot of cells. And notice the big atypical megakaryocytes. And then when it becomes very fibrotic, it becomes very pink, and the number of cells is fewer. The pink here is fibrous tissue. And then as an end stage, you might also get more bone formed. We don't really understand quite how that happens, but bone formation and very irregular spicules is an abnormal feature. And that's a final picture of a really kind of end stage myelofibrosis. I was going to talk about why sometimes there are some difficulties in establishing the diagnosis, and I'll just show you this, which is just to emphasize that it's the assessment of these various features, how many cells there are, how much fibrosis there are, how atypical the megakaryocytes are. It's a subjective assessment, and this was 3 different pathologists looking at the same things, and you don't need to remember any detail other than that the distribution of the segments around the pie chart are very different for each person. Each person interprets the same things differently, and hence we might come to a different conclusion. So I want to end there, and I'm sorry there has been a lot of information. I hope I haven't horrified you by showing you too many things that were unfamiliar. I hope it hasn't been too boring for you, because it's not very technical. It's rather artistic maybe, but it's part of what we do. And I may have painted the megakaryocytes as being the villains of the piece, but they're not. They're magnificent cells that are normally doing a fantastic job for us, creating platelets. And I've shown you how carefully they tie to protect our bone marrows from fibrosis. And one of the areas of ongoing research that's coming about through the interest in inflammation as part of what's going on in the myeloproliferative neoplasms is trying to help us understand how can we switch off this inappropriate shedding of platelets and the inappropriate of activation of platelets, which leads to fibrosis. So, leaving you with Mr. Magnificent Megakaryocyte, I will shut up. Thank you very much for your attention.